All right. Good evening, folks. Out here. Got a couple people. I'm for sure people start popping on here now that we just made it live. Give them a second here. Yep, here they come. All right. Good evening, everybody. Welcome back for part 2 of the series with Dr. Mike Lovich. And we are now ready to hand it over to him to finish up what he started on Tuesday. So whenever you're ready, Mike, it's yours.
Great. Before we start, do we have any questions based off what we talked about on Tuesday? If you have any questions, just feel free to post them in the chat or the Q&A, or raise your hand. And I think Chris is going to be monitoring those hands raising. So feel free to interrupt. Feel free to ask questions. This is a learning experience for everybody. So we want to make sure that everybody's getting the best experience out there. So Chris, I need to have share my ability to share a screen real quick.
Yep, stand by here. Let's see.
Standing by.
Oops, it's not the right one. All right. Do you have the option to do so now?
I do.
There you go. All right.
All right. So this is where we left off. So I'm going to review some of the key point that I was trying to get across in the parasympathetic effect system, which is essentially sympathetic. When you have sympathetic activation, which comes from the IML cell column in this from T1 to L2 in your spinal cord, which receives information from your hypothalamus and your mesencephalic reticular formation. In other words, sympathetics come from hypothalamic and midbrain activation. To get a little more detailed with that, sympathetics come from lowering hypothalamus and increasing anterior midbrain activation, also known as a ventral tegmentum. Okay, so you have two different ways that sympathetics can increase, and when sympathetics increase through the IML, the entire body gets sympathetic output. The entire body gets sympathetic drive. When parasympathetics are activated, you get parasympathetic activity in chunks, in different areas where they need it. There's only a few ways that I know of that I can get full body parasympathetic activity. One of them is the diving reflex, which is where you put cold ice packs or something, or cold water on somebody's face, and that creates a full body parasympathetic activation. It's like a mimicking. If you swim in ice in colder water, it pulls blood away from the extremities to keep it in the core and the trunk. But other than the diving reflex, I don't know of many other ways in order to get full parasympathetic activity. So when you're trying to think of things that do set parasympathetic effects, like vagus nerve stim or stuff like that, remember that the vagus nerve stim that you're thinking about there doesn't necessarily do like full parasympathetic activity. And when you're trying to stimulate parasympathetics at a patient, make sure you're stimulating the right parasympathetic part, not just generic parasympathetic. That's what happens when we sort of default into the oversimplistic psychological models of sympathetic versus parasympathetic of, oh, they're stressed, or they're calm. We need to stick to more of a physical, clinical nature to really understand what's happening in the body. So one of the things that I was bringing up before, and you might have noticed a couple times, I was talking about how this patient in particular was having trouble sleeping, had insomnia. And I know that since we're on this parasympathetic kick, we're also talking about what are some things that you might have heard of that you can do for improving parasympathetics. Since she's already had something like a sleep apnea test done where she was using a CPAP machine, we know that sleep apnea is something that can be improved or needs to be improved. Either it's tested by a sleep study, and if your respirations permitted is below a certain number, then you qualify for insurance to give you an oral apparatus or a CPAP machine. The thing is, a lot of practitioners I'm noticing are trying to use vagus nerve stimulation, and they just believe because in the line of logic that has been explained to me by some of these practitioners, unfortunately more than once, is parasympathetic good, vagus nerve parasympathetic, vagus nerve stimulation good. And that's the entirety of clinical reasoning. And if good thing doesn't happen or bad things continue to happen, more vagus nerve stimulation needed. There's an example of how vagus nerve stimulation can exacerbate sleep apnea. And it was put together really succinctly and really well in a Facebook post by Roy Wilkins. So I just figured I just copied that post and put it down here, because instead of me trying to make it up myself into something that's simple and easy to understand. So since sleep apnea is measured by a reduced rate of respirations, vagal nerve stimulation can cause and aggravate sleep apnea. VNS stimulates vagal afferents, affecting the dorsal motor nucleus of cranial nerve 10 and nucleus ambiguus. Tying it into other things, what does dorsal motor nucleus of cranial nerve 10 do? All the muscles that are associated with cranial nerve 10. Levator veli palatini that you're looking for in the throat when you're shining the line there and having them go ah. You're also looking at what goes into the cranial nerve 10, what areas fire into dorsal motor nucleus of 10. Smell goes directly into that area on the ipsilateral side, so you can correlate that to see if there's something going on with specifically the dorsal motor nucleus. Efferents from dorsal motor nucleus of 10 and nucleus ambiguus constrict the airways. Vagal afferents also affect the reticular formation, which is going to be in the brainstem, affecting depth and rate of respiration, reducing depth and rate. This causes and could aggravate hypoxic events associated with sleep disorder styled breathing, like sleep apnea and or hypoventilation. Both of these are seen in obese patients, and both of these are seen in COPD patients. And it's a pathological end. But when you're not talking about pathological and you're talking functional, you're talking about pathophysiological, we got to remember that if we are trying to improve their sleep, increasing vagus nerve output, which would then create more vagal nerve tone on the muscles that it goes to, which is the levator veli palatini and the soft palate, and the muscles of the throat, is going to constrict the airway. And it's also going to reduce reticular formation output and reduce the rate of respiration. So VNS can help with insomnia and anxiety, depression, but it may cause or aggravate sleep apnea and make it worse. So it's not a therapy you want to do if they have sleep apnea or they're near it. If they're an obese patient, parasympathetic stimulation creates more absorption of nutrients. It creates more rest and digest, which means that an obese patient probably already has a higher state of parasympathetic activity. If they're stressed out and obese, it doesn't mean that they're sympathetic and not parasympathetic. It means they're probably both, but the fluctuation between the two is unstable. So just the clinical correlation that I want people to understand: don't do VNS willy-nilly, especially don't do it if they're at risk of having some sort of sleep apnea. Okay, coordination, station, and gait. And then we already watched the video on video oculography. We already threw that in there. We did that last time. And then coordination station and gait. I don't have that video on this computer. I was trying to find it. I didn't have access to it. Basically, so let's go through this and form our clinical impression. After one of our breaks, I'll see if I can find that video and we'll go through that one. But we know that she has POTS based on the spontaneous spikes in pulse, even when sleeping, and the syncopal episodes. But what is actually going on in her brain? What can we reasonably assume, and what are inferences? What are things that we are saying, yes, we have data that supports this, and what are things that we're like, okay, well, this might be happening because. So if we're going through her top 5 health concerns, we know that she has tachycardia. We know that she has a dysregulation of the cardiorespiratory centers in the lower brainstem. We also know that she has difficulty adjusting to light, which means that it's the top of the brainstem. That's the superior colliculus. That's also the occipital lobe, except she didn't really have any symptoms occipital lobe. So we're going to assume that if she doesn't have anything else going on occipital, then we're going to say, okay, maybe it's a superior colliculus issue. And if it's a superior colliculus issue, we need to start looking for other things that could be midbrain related that would guide our treatment to rehabbing part of the midbrain or all of the midbrain. We had inconsistent reaction to water and food. So we knew we had some sympathetic parasympathetic dysregulation and dysautonomia. And we were going to assume that it was onus nucleus or one of the nuclei that regulated it and not a spasic occupying lesion. We knew that she had sleep and insomnia issues. So we know that her hypothalamus is jacked, and if her hypothalamus is jacked, then that's gonna jack up the autonomic systems. And if her hypothalamus and autonomic systems are jacked, that means that her midbrain, that's gonna come right back to the midbrain area. We know that she has insomnia, nightmares. Nightmares can be related to POTS in a way where the nightmares start when the same mechanism in the brain that's allowing the brainstem to deregulate and cause a spike in blood pressure can also be perceived through another pathway that goes further along through to the frontal lobe to say that there's nightmares. So it's not like, oh, scary thought makes high pulse. It's things that are creating high pulse are also presenting a scary thought. And then heart flare-ups in the middle of the night, according to the Apple Watch, is something that we're also saying is dysregulation. And the memory and the concentration issues are going to be medial temporal lobe stuff. So we're seeing a bunch of different things that all fire together, that all come together to say that we have a few points. We don't have like 30 different things that seem to be unrelated. We've got like one significant pattern that needs to be rehabilitated. So, more questions. What areas are involved? Since the hypothalamus is involved, are the HPT and the HPA axes involved? We can reasonably assume, yes, this is an inference. That yes, she may have some things that are coming across as adrenal, and yes, she sweats a lot more. She may have some things that are coming across as thyroid, and yeah, if you looked at her, you would say, oh, maybe she has a hypothyroid situation going on. Not the case. But chasing thyroid and chasing adrenal when it's the H and the P instead of the T or the A, that could lead you down the wrong path. And it's good to be able to measure and at least recognize when it's a hypothalamic problem and maybe a circuit of Pepez problem. Because remember, the hypothalamus is intimately involved in the circuit of Pepez, which is a series of structures in the brain that are associated with your circadian rhythm. Hypothalamus, your subthalamic nucleus, your pineal gland, and their midline cerebellum all fire together in a loop as part of the circuit of Pepez that create that affecting and create changes in your circadian rhythm. And if that is dysregulated or dysfunctional, then of course you're going to have sleep disturbances. So is the cerebellum involved? So I would argue, yes, this is another inference. She didn't have any tests specifically that showed, hey, she was dysregulated or she was having pathological cerebellar findings. But we know that the vestibular system fires into the cerebellum, and we know that the vestibular system and the cerebellum fire into the brainstem to create activation and control. So we were talking about 2 days ago, we were talking about the cerebellum has its 4 deep nuclei. And then you have your Purkinje cell layer that does surround inhibition over it. And then in order to move some muscles, creates a little bit of a window to allow just enough through to create the activation that we want. If it lets too much through, it'll create too much activation and it'll look like a movement disorder or hyperkinetic movement or hypermetria of movement or hypermetria of thought or a hyperkinetic thought. Because remember, the cerebellum is not only coordination and balance of muscle movement, but it's also coordination and balance of thought, because thoughts are motor pathways in the brain. Is the vestibular system involved? Yes. We found vestibular deficits in goggles because we found things that were correlated in a decompensated VOR reflex. Now, what's the difference between decompensation and degeneration? Decompensation means that it's just kicked off a little bit and it just needs to be fine-tuned, reconnected. We just need to retrain the inner ear. Yes, this is how the reflex is supposed to work. Get this work done. What does degeneration mean? Degeneration means that there's actual degeneration in the inner ear, and that kicking off or that damage or that dysfunctionality of the inner ear is going to be a consistent problem for people. And if it's a consistent problem, that means that they're going to need some sort of rehab indefinitely. What are things that can cause degeneration instead of decompensation? Decompensation you'll find in traumatic injuries like concussion. You'll find in you'll also find this in degenerative diseases like Parkinson's or Alzheimer's, where the degeneration isn't occurring in the inner ear, but the decompensation in it is creating issues. There's a paper that has showed that unilateral vestibular deficits creates an increase in immune system response. In other words, you can either take a bunch of anti-inflammatories like turmeric, resveratrol, bromelain, that kind of stuff, or you can improve the vestibular input and reduce that excessive inflammatory response. So from a very chiropractic perspective, if you want to not chase symptoms and actually get to the cause, going after a vestibular deficit that could be creating that inflammatory response is going to stop the problem, as opposed to just trying to give anti-inflammatories to reduce it. From a degenerative perspective, there's a paper, Bisht and Bisht, B-I-S-H-T. It's called Ototoxicity, the Hidden Menace. Remember how we started off this meeting? We started off with talking about all these different medications that she's been on, and I was urging you to understand medications, and I was volunteering Dr. Riggin to provide his notes from University of Western States, because it's so important to at least understand the basics of classes and their actions of medications, because if you have a medication that's causing the issue, that can be a conversation that you urge that the patient talk with their doctor, or you just say, hey, can I get a word in with your doctor? And you connect with their doctor and you say, look, I see that they're on this medication. I think it's affecting my patient in this way. Here's a paper showing that ototoxicity creates degeneration. Ototoxicity is a known issue with this medication. Is there any other medication we can put this person on that you'd be comfortable with? Create a relationship with a doctor, and also put the patient's best interest in mind. So what is so look for that paper. It's called Ototoxicity, the Hidden Menace. It's a paper that I think everybody should have on hand. It is the only thing that's on my desktop routinely. Everything else gets put in folders. It's the one thing that I want to have available at all times, just in case. What parts of the brainstem are involved? So we already chatted about this, and really it's all three. But what area do we want to target a lot? We want to target that lower brainstem to help regulate parasympathetic activation. and we want to target that upper brain stem to help use the cerebellum to activate and control midbrain activation and midbrain drive, so that way the neurotransmitter centers that will then relay through to the frontal lobe for this patient are going to be calmed down and controlled instead of kind of doing whatever they want. What supplements would I recommend? Because that's easy to do and income for the business, right? I recommended one thing for this patient, and it wasn't even when we started. And I'm going to show you what that thing was later. But with this patient, even though she's a POTS patient, even though she's got all this dysregulation, we did not start with any supplementation because I don't want to do too many changes and change too many variables at once. I want to see what my therapies are going to do and how they're going to affect the brain, so that way I can make appropriate changes and not think, okay, well, what's going on there? So my assessment, I usually write a little bit of a longer assessment than this. I think I changed it after this patient to be a little more in depth, but this patient's objective examination findings are highly suggestive of POTS and essentially maintained vestibulopathy. She's demonstrated soft neurological findings detailed above that are consistent with the proposed diagnosis. Appropriate differentials include migraine, because I always got to keep something on the side there just in case that I'm like, okay, what if it's not POTS? What if nothing responds to it? And migraine would be my next concern. But I think that at this point, I'm thinking that if I go after a vestibulopathy on here, then we should see her POTS symptoms improve. So we just went through what's going on with each of her top 5 health concerns. We kind of went out of order here. So how do we start the treatment process? This is what I do to work with a POTS patient. I start the treatment process by giving a home exercise program. I do not want them to be doing exercises at home that are so complicated that it can make them worse. But I do want them doing exercises that are very easy to do, because we want their brain to start building pathways immediately. I recommend that my patients do home exercises for the brain 3 to 5 times a day. And my athletes are going to end up doing it 10 times a day. And everybody else I'm going to be lucky if they do it once a day. But most patients, if I say 3 to 5 times a day, they usually get in once a day. If I tell them to do it once a day, then they'll do it like once a week. So the idea is, from a functional neurological perspective, the way we do neurorehabilitation is we're building pathways in the brain. We're taking a weak pathway that goes from cerebellum to midbrain and midbrain to frontal lobe. And what we're trying to do is exercise it in a way that it becomes a stronger pathway. If you remember at the beginning of 2 days ago, we were talking about how when we were talking about activation, intensity of activation, time to summation, when we talk about the neurophysiological part that I think is very important for people to understand, if we want to create stronger neurons, we need to create larger neurons that have more protein, which makes them have a more negative resting rate, which means that they're less likely to have a hair trigger firing mechanism, and we can have more stable neurological processes. So this is the exercises that I gave her. I gave her right hand, right foot complex movements. What that is slow arm circles about the size of a large pizza, 1 in each direction. Then slow leg circles, 1 in each direction. Then I had them do arm and leg together, 1 in each direction. And then I have them do arm and legs contraphasic, 1 in each direction. The reason for contraphasic is it's still the same circle, but there are different points of the phase. So it's going to be like this. And it creates a lot more thought. The point of exercise number 1 is to increase activation of the cerebellum. And then what we're going to do is, with all that cerebellar output, we're going to then do a control exercise, polytasking. I have them turn on a metronome at 40 beats per minute, cross their arms over their chest, lift their fingers up, and tap. as close as they can to the beat. They're not trying to react to the beat. They're trying to predict the beat and beyond the beat. And so the point is, you start with a cerebellar activation and you come in with a control exercise. Then I'm doing right rotation with a left optokinetic stimulus. It means we're getting right vestibular horizontal activation. And then I'm giving a left optokinetic, which is going to further wind up the midbrain in a controlled way. And then, which is another activation exercise, and then I'm giving a right horizontal canalith activation. So again, same thing, right head turn, slowly back, because we want to get the fluid moving in one direction and not canceling it out. And we do that into horizontal. So 2 passes side to side. Looking at a single target that's further than arm's length away, but eye level. And then we do 2 passes up and down. So horizontal and vertical gaze stabilization. So we do cerebellar activation into a basal ganglionic control mechanism, into a vestibular activation, into a frontal lobe control mechanism, a frontoparietal lobe control mechanism. So you can see what we're doing is we're training the brain to activate and then control and use that energy. So we're building and controlling and building and controlling. And it's a big deal to do it in this order, in this way, because if you just ramp, then you may ramp them up to a point where they go, where you pass their metabolic threshold. And then you have to deal with them having more symptoms. That's why you can't just say, okay, you do 12 of these exercises, you do 10 reps, 3 sets of 10, because the individual person may not be able to do that. And if you have them push through a fatigue point, they're going to get worse instead of getting better. So I gave her 4 days to start this home exercise program. And then I saw her in office the next week. So she presents for a mini intensive. What we do at our office are mini intensives. You may have heard other people do full-on intensives. Currently in the functional neurology world, you have people doing 2-week intensives, 1-week intensives, where a patient will fly in or come in from wherever, and they'd be hanging out in the office, getting treated 5 to 7 times a day, Monday through Friday, and then they'll do it again the following week. And then if they, or they'll do a 1-week intensive. In my office, we do full day intensives, but we also do mini intensives because we want to get the repetition and intensity in the brain boot camp to get neurons firing and get enough repetition with rest in between to create a pathway so they don't go home, or like, let's say they came in 3 times a week instead of 3 times in one day in a morning. So if they came in 3 times a week, Monday, Wednesday, Friday, the rest of we did a little bit of activation, and then they have a day, like 48 hours until we did a little more activation. But within that 48 hours, they have all this time to create poor compensations and mess themselves up. So if we're trying to get them better as quickly as possible, what we'll do is we'll say, all right, why don't you come in and we're going to do 3 sessions. And in these 3 sessions, we're going to do a half-hour rehab and then give you rest, and then another half-hour rehab and then give you rest, and then another half-hour of rehab. Not only does that allow us to do more rehab in office because we don't have to spend a little bit of time going, okay, how's it going? What happened in the last 48 hours? We can just get right to town. Like after the first and second rest, it's like, all right, we're doing more rehab. And then the patient ends up getting better faster because we've taken approximately the same 90 minutes of care a week, but we've bunched it up into a way where we can create more targeted neuroplasticity at once and make them more resilient against things in their week, the rest of the week, that may make them worse. So after last time, they report feeling an improvement in their ability to go upstairs, work out, and have a longer duration between passing out episodes. Patients have been diligent with the home exercise program. In other words, I did not do any treatment with her. All I did was do an exam and give her a real generic home exercise program. And that's what she came in 4 days later. That's a kind of a big deal. So this is how we document our mini intensive. So session 1 was at 10 a.m. We did some gait testing that showed a left side cantilever arm swing provoked by cognitive dual tasking. So what does that mean? That means that when she's walking, she had less arm swing in the left side than the right side. Why is arm swing important? So we were talking about this 2 days ago briefly, but arm swing is important because it, through the fascial systems, creates efficiency and energy transfer and energy conservation. So as you're walking, you don't use as much energy. The less you move your arms, the more energy your body has to do to walk. What does a left side cantilever arm swing mean? That means that not only was the left side not swinging as much, but it was swinging out to the side, which means that she thought she was falling to the right. Whether she was falling to the right or not, her perception subconsciously was that she was, and she needed to balance out. Provoked by cognitive dual tasking means when we did cognitive dual tasking, which is while they're walking, you have them do something obnoxiously difficult. Let's do something like, all right, while walking back to me, I want you to say every other letter of the alphabet out loud, starting with the letter B. And when they do, what does that do? That's going to be your frontal areas, your prefrontal cortex, your executive decision-making skills. That's also going to be the back of your frontal lobe, which is going to be your M1 and your supplementary motor area. And because they're saying it out loud, that's also going to be Broca's motor cortex. So we're taking 3 different parts of the frontal lobe saying, okay, now do them all at once. And with only a finite number of resources, made worse by a possible inflammatory process going on because of vestibular issues. Let's see what breaks down. And what broke down was she thought she was just falling to the right the whole time. Romberg test on perturbation foam with eyes closed, neck extension, showed left anterior and right posterior sway. So here's the thing about Romberg test. When you put a patient on a AirX pad, like the blue foam pad, with their feet shoulder width apart to start, like first you want to put them on flat ground, put their feet together and see if they fall down. If they fall down or if they're not stable on flat ground, do not put them on an AirX pad. They cannot handle that. And it's a little embarrassing for the doctor. After you test that, you put them on the foam pad, on an AirX pad is what I use. And I have them put feet shoulder width apart. The reason why I don't put the feet together is because A, I want a way to make it more difficult. B, being on the foam pad is difficult enough that I should be able to see something if I know what I'm looking for. What am I looking for? As I'm standing up on the foam pad, I'm looking for first the initial direction of sway. It may be very slight, but that's the direction you're looking for. That you have them look straight ahead, close their eyes, and when they close their eyes, the initial direction of sway, and then immediately they're going to compensate for it because they don't want to fall down. So what is the compensation? The compensation is always at a right angle to the initial direction of sway. So this patient showed left anterior, right posterior sway. So left anterior, right posterior sway. That means that if I documented it this way, that means that if this is the compensation, the weakness has to be left posterior canal or right anterior canal. Does that make sense? And she also had pitch plane tutubations, which means that while she's on the foam pad, she's like bouncing on there too. That's an otolithic problem. So now we're not only seeing canalith issues, we're seeing otolith issues. And she had moderate oscillations in the horizontal plane evoked at 10 degrees right with horizontal pursuits. So when I was watching her eyes pursue, she had an oscillation at this point where her eyes would just go. An oscillation is a catch-up saccade. is a hypermetric catch-up saccade. So it goes over and then it comes back and then it comes over and then it comes back. And has it very rapidly and then it keeps going. I saw that in a patient I had today. I was pursuing down. I was like, so yes, she can move her eyes in the right direction. Yes, she can do the thing and she's not pathologically ablative. But can you imagine if you were looking around and every time you got to this point here, your eyes started shaking? How accurate would the data be and how much stress would your brain be under if a whole part of your visual field is kind of like a black hole? So that's something we want to improve. Then we did RPS. So we started off with performing RPSS, so repetitive pulsed somatosensory stimulus. Excuse me. So we did RPSS, the hypoglossal nerve bilaterally. Why do we do it to the tongue? The reason why we do it to the tongue, the hypoglossal nerve, is because the hypoglossal nerve contains cranial nerve sensory attachment points and motor attachment points from all three areas of the brainstem. And if you hit both sides at the same time, you get bilateral. So you're getting full brainstem activation. So what does that do? When you put a biphasic electrical stimulus, and it has to be biphasic to get the best results. So it's either RPSS, somatosensory evoked potentials, SSEP, or high voltage galvanic, HVG. Those are the three that are biphasic curves because it mimics the mimics the waveform of a neuron firing. So when you use biphasic waveform and you stimulate an area, what you're doing is you're creating electrical activation in the neuron pools inside the nuclei that allow output into the cranial nerves. So what that means is we did like 10 seconds of stimulus, 5 to 10 seconds that's like priming the pump. And then we did some exercises right afterwards. And I did some gaze stabilization right after, because all I care about when I start working with a patient is, can I get their eyes to stay on a target? Because if I can't get their eyes to stay on a target, then they can't follow a target and they can't jump to other targets because they can't even see one target. That's my biggest gripe with people who are treating concussions and they just do a bunch of back and forth or side to side or up and down, and their gaze stability sucks. And rules of the road: if you don't have gaze stability, you can't graduate to horizontal pursuits, and you can't graduate to vertical pursuits, to then graduate to depth plane. You need to build everything up because there's nuclei that depend on prior nuclei that need to be built up before then. So for gaze stability, you're looking at your nucleus prepositus hypoglossi. That is your NPH. That is, if it's hypoglossi, that means it's your hypoglossal nerve nucleus. Why do we do sensory stimulus to the tongue? Because not only does it light up the whole brainstem, it especially lights up the hypoglossal nucleus, which is key for keeping eyes on a target. All right. And then I was doing supine gaze stability with her. So in other words, when I was doing all my visual and vestibular exercises with her when I started, I wasn't doing it with her sitting up or standing up or sitting in a chair. I had her on her back, because I need to figure out at what point does the POTS kick in. And what you do to treat POTS is you do the same stuff you do with any other neurological rehab patient, but you start supine to reduce the amount of gravitational effects, and then you slowly repeat the same routine of exercises throughout the treatment process. So because I was doing 3 in a day, we started like this, and then every so often when I thought she was able to do it, I'd raise her up a little bit, and then raise her up a little bit more, and then raise her up a little bit more. And we always keep her under the threshold of when she would get POTS to begin with, because we need to make sure that all these systems are good before we deal with the systems that are bad. All right, then I did polytasking with her with the auditory stimulus to the right ear. In other words, we were trying to drive left brain activation, and even though the cochlear pathway is bilateral, it biases the right ear over the left ear. And then we performed some right vestibular activation to get the vestibular system moving and get the midbrain activated into a downward optokinetic stimulus, because part of the issue that she had was when she's sitting, remember we had that nystagmus in the video that we showed 2 days ago? In order to mitigate that nystagmus, part of it was we had to convince her brain that when she's sitting up straight, she isn't falling backwards. So we had to use vestibular activation into a mimicked movement when she did not feel movement in her neck and body, so that way she can create the error processing pathway that she can then use in normal life, so she wouldn't think she's falling backwards if she's like, oh, I don't feel that going on in my neck, I don't see this going on in the world, I must not be falling backwards, let's ignore that now. Then I gave her about a half hour of rest because her systems were pretty fragile to begin with. So we probably did around 20 minutes, 25 minutes of rehab, and I had her sit there, then literally shut the lights off, and I walked out of the room and had her take a nap for 30, 35 minutes. Then we retested gait testing. Improved arm swing bilaterally, no freezing provoked by cognitive dual tasking. Right away, just by doing that first session, she no longer had any cantilever arm swing. Repeat vertical saccade, so look up, look down, look up, look down, look up, look down. Showed a slight left accommodation spasm and upward gaze. What does that mean? That means that the eye is slamming in. That means that her her perception of where she is in space still has her as leaning backwards and also to the right. Make sure I have that right. No, leaning backwards and to the left, because she thinks this left eye, when she goes back into the left, that left eye thinks that's where straight ahead is. So we had to work on that. So, and we use monocular optokinetic testing. So what I was doing is because she was complaining about her left eye, she was like, oh, this just is weird. This has always been weird. So I was like, all right. So I took my phone, I did the optokinetic testing, and I would look to see how it moved independently. It looked like there was like a sluggish left eye. Like the left eye just was a little bit slower than the other side, but it wasn't really much slower than the other side. So I wasn't worried about internuclear ophthalmoplegia or some sort of demyelinating disease along the medial lemniscus. So what did I do? I did some right horizontal canal activation with a downward optokinetic stimulus into horizontal gaze. So you see how we're doing like a Street Fighter combo moves? We're trying to create activation, create another set of activation, and then create a control mechanism over it. So that way we can activate and the brain can use that input instead of saying, oh, you just pressed the gas, you just filled up the tank and slammed on the gas and the engine still doesn't work. And we're training the engine to work with somebody slamming on the gas. We also did a convergent pursuit into a prosaccade upward left into a divergent pursuit further upward left. So what are we doing? We're trying to pull that left eye out from slamming in when it goes up. And then we did some monocular left optokinetic stimulus and some horizontal gaze stability to close everything down. I view gaze stability as like hitting the save box in a video game. You're taking everything you just worked on and activated, and you're just bringing it all together to create their body's perception of where they are in relation to the world around them, so that way they can, and their ability to see a target, because you're changing the maps in the brain and you're changing the perspective in which the brain is able to react to things. So you got to make sure that when you're creating those changes, that you're giving the brain a chance to figure out where it is in space again with this new information and new systems that have kicked on. All right, I gave her another like half hour or so of rest. And then we did a Romberg test, and we saw much improved stability based on the last time we did it. And her horizontal pursuits were more metric. So that oscillation, gone. She performed right horizontal canalith activation into downward optokinetic into horizontal gaze stabilization. So in other words, this third session, we've kind of already figured out what we needed to hit that session. So I just did another round of it. Simple, easy. Because we knew we were going the right direction, we just hit it home. I get a text. So then I say, okay, we'll see you in a week, because we're going to do mini intensives 3 times in a morning instead of multiple times a week, because we're going to get better results. And also it's less interrupted to her daily schedule and she can work more. So I get a text from her 4 days later. Basically, she says she was having a little bit of an issue where she had a spike, but I was like, are you all right? And she's like, absolutely. It seems to have restabilized for the day, have done the stairs twice, haven't gone over 140 beats per minute. Hopefully just a fluke. She's referring to the one spike that she had before. Hobby Lobby is generally a trigger. Wow, I can't speak today. Sorry, guys. Hobby Lobby is generally a triggering place for me, but was not today. So that's huge. Weird win. Goodbye money now, I guess. So in other words, remember we were talking about how our optokinetics weren't really good? When you're going through stores, especially large, big box stores with fluorescent lighting on top, what you're really doing is you're creating a bad situation for the brain. Fluorescent lighting, if you've ever done this, grab your phone, turn it to the slow-mo video setting, aim it at your fluorescent lights, and press go. Go watch the video, and you'll see it's just a pulsing flash the whole time. For patients' brains that are moving at different rates and perceiving information at different rates in the quote-unquote normal brain, they're picking that crap up. That's why they're getting migraines. That's why they're getting symptoms. That's why their visual systems are trashed, because they're getting flashes of light instead of getting constant light. So it's like getting a strobe effect in a non-perceptive level. And that's not good for your brain. You need your brain to be able to speed up to a point faster than that so it can handle those changes and handle those flashes. So on top of that, she was having trouble. But also when you're going through a store with shelves and just a ton of items there, that's another optokinetic. When you're turning and you have these rows and columns, you're essentially putting yourself in a position where just by turning in the store or just by walking down the aisle, you're giving yourself optokinetics on both sides. And if you have asymmetric tolerance to optokinetics, that's going to get your body to start twisting in compensation for that. So that way, and then you're going to start getting symptoms. So she was never able to shop. It was really funny. So we were talking about this, and she was saying that whenever she had to shop, she would always go in and turn right and then walk around the store so everything was to the left of her. And that was the only way she would be able to tolerate it. If she ever turned to the left and had to deal with everything to the right of her, it would just give her a really bad day and she'd have to leave the store. So we're seeing some improvement now. Quality of life is improving. She can now go spend her money. So now this is a week later. Patient presents for a mini intensive. After last time, she reports that she was mentally exhausted, took a nap, crashed the next day quicker than normal. However, she rebounded and had a great week. She's been able to walk the dog during the heat of day. She didn't even realize that she was avoiding hot days here in Colorado because she couldn't handle regulating her body temperature during hot days. So she was avoiding walking the dog during that. She feels like her eyes has been different, but she also feels like there's a lot of stimulus. She can't focus on the one thing she's been trying to focus on, but she was able to work out pretty hard with bent over exercises, and she hasn't had any issues. She's on a beta blocker right before bed, but she's been spiking at night. So the spiking at night is still happening. She typically falls asleep around 12:30, 1 a.m. and feels her pulse going up in the first 1.5 hours. So we still haven't knocked all this stuff out, but she's getting better. Her sleep hygiene looks like a dog walk right before sundown, dinner before that, and she'll read she'll read paper books and avoid screens as much as possible. She's doing good sleep hygiene. She'll play music. She sleeps a little bit colder. She goes to bed feeling cold and wakes up warm. So she's doing good hygiene to try and work that, but you can only do sleep hygiene on and change the environment so much if your body's dysregulation is the issue. So day of, so after we worked today, this was literally like she went home and then she texted the office saying, today is the first day in years I have woke up feeling good. I would be lying to you if I said it didn't make me cry. I went on a morning run with a pup without a single symptom, ran up the stairs, heart got up to 160 on the run, but wouldn't go over 110 on the stairs. This is insane. I feel normal for the first time in a while. Thank you so much. All right, we're going to take a quick 9-minute break, so we'll pick up at the hour. If you have any questions, comments, concerns, complaints, jokes, throw them in the chat in the question and answer. All right, great. So we're kind of just going through like we're through the feel good end of this little story, and then we'll have plenty of time for questions afterwards. So essentially, the day of, she texted me that, and then the day after, and 4 days later, she sent me the printout from her Apple Watch. So if you look at here, so let's review what her other ones looked like. Did I have them up here? Nope, I didn't. I have them down below. Okay. So what we're looking at here is before we had images that were showing a bunch of spikes. Now she's just getting spikes when she's walking or doing some sort of training. So she's walking, she's doing some functional strength training. She's getting spiked, but they're not really spikes. They're like normal exercise. And then a couple of days later, you can see that she got a huge spike in the middle of the night, but during the day, she didn't get a single spike at all. And she did a hike. She did a 14er on this day. So she hiked at high altitude. And she had no issue whatsoever, even during the hike. So that's a big deal. Now, remember those pupil measurements we did, the Reflex Pro app? This is our printout. So the right eye, so the baseline is the orange line. The right eye now is having a much more appropriate response where it shrinks down and it stays a little longer before it fatigues, and then it tries again before it fatigues. The left eye was even worse, where the baseline, this orange line, would shrink down and before it got bigger. But the pink line, which is the left eye now, is gotten significantly better. I mean, it's not completely better, but you can see how it's kind of on average just a little bit lower than the baseline, which means that now the pupils are starting to be less big. Smaller pupils means better regulation, as long as it's not a too small pupil. And now when we compare the pupils to each other, you can see how they're starting to be more of the same shape, as opposed to before where we had big differences in functionality. So 1 week later, and now we're 18 days into care. After last time, they report feeling much better. She's been able to have a hot shower 3 times with no symptoms. She's been able to run almost every day and go for hikes, and with a slightly higher heart rate, but no spikes. She's been able to work for 35 to 45 minutes at a time, and she's had more energy around the house, and she's able to bend over, which is still a big deal for POTS patients, just being able to bend over. Her symptom severity score, if you remember that from the beginning, was a 79. It went to 17 in 18 days. After 11 years of dealing with these symptoms, she had a 74% decrease. Her total number of symptoms went from 20 to 15. The following completely resolved. She no longer had any low-grade nausea that was just there all the time. Her sensitivity to noise, so much better. Feeling like she's in a fog, completely gone. Drowsiness and irritability, she's just in a better mood all the time because she doesn't feel like she's struggling. We recommended that she follow up in 3 months, and we set her as a call me when you need me patient. I'm not a fan of maintenance care personally, especially from a neuro care thing, because from a neurological maintenance care thing, they should go to them, get regular musculoskeletal care. That's what you're getting week to week. For neurological rehab, no, we could just call me when your symptoms come back. They should stay away for a relatively long period of time. But what about the pupils? So we just looked at the graph from a week previously. What do they look like now? The right eye compared to the baseline. So the right eye, so the baseline was sluggish, then it would release, and then it would come down and release, and then come down and release and come down. Now it came down, it shrunk, and stayed pretty good with a slow kind of release, and then it shrunk again, and then it fatigued out. That is a much better graph. What did the left eye do? The left eye kicked butt. The left eye started off smaller. It didn't have the inappropriate reflex where it got bigger first and then small. It got small right away, and it shrunk, and it stayed, and then it got a tiny bit bigger, and then you got into some hippus here. So we still have work to do, but you know what? She's at a point where she doesn't really need to be in active care anymore. So what does it look like together? Together, you can see how they're both significantly smaller. This left eye is now doing better than the right eye, because before the left eye was struggling a ton more. And you can see how this is a lot, it never fatigues. It never comes back up to the size that the pupil started. It stays smaller. That's what we're looking for. That's what we care about. We care that these autonomic systems are not too much or too much. We care that they are stable and strong in the middle. What are her thoughts on the matter? And this is kind of like the feel-good part. Her thoughts on the matter are, I did a thing. She enrolled in a neuroscience bachelor's degree program to go into research at Arizona State University through their online program, because she wants to be involved in dysautonomia research, since neuroscience and what we did in office has helped her so much. I appreciated everything. Thank you for everything. This choice is only made because of the progress I've had in the last few weeks with you. So I couldn't have done it without you. So the point is, with her memory systems were tanking, she thought she'd never be able to go back to college because she thought she'd never be able to get through classes with the way her memory was working. We fixed it. She fixed it. She did the work. She did the exercises. And she got to a point where now she's able to go back to school for a neuroscience bachelor's, and she's passionate about it. And now her goal is to go into bench work and bench research, so that way she can help other people who are struggling from dysautonomia and POTS. This, she sent me July 13th. In the middle of July, I get a random text from her saying, I just did a workout. So she did a half-hour workout with a peak of 174, an average of 156, and there are no spikes. She did a high-intensity workout for the first time in years. We're talking about like over a decade. She did a high-intensity workout, and she was fine. She did not burn out at the end. She did not get tanked for a couple days afterwards. She just did her workout, did her recovery, and she was good. That steady workout. And that's where we're ending. That's the whole story, is POTS can be improved, and POTS can be improved quickly. if you know what to look for, and if you have the clinical mindset and you're working on it, just like we went over today, if you're able to think through these processes and look for the things that you need to see and find the things and then know how to react to them and treat them, you can get a POTS patient who's been dealing with it for, what was it? 11 years of weekly dealing with her symptoms. We got her life back in 18 days. So we've got plenty of time for questions, comments, concerns, and jokes. What do you got? Chris, anything?
Don't see anything yet, but I got a question. How long did it take you to become proficient at this, at applying this into a practice? You know, how long did it take to learn this information and then apply it
So
in a clinical setting?
I just created the first step in getting a residency program going up for doctors who want to do functional neurology. The hardest part about getting into functional neurology is the amount of time it takes to learn all the didactic material. So the didactic stuff is not much further than stuff you learn in chiropractic school, but the application of it is the hardest part. And then, I'm sorry, the application of it is hard, but then the clinical thought process and the observation skills are by far the hardest part. The easiest way to learn this stuff is to have somebody who knows what they're looking for, knows what they're doing, to point stuff out for you and to show you this is what I'm seeing, and then walk you through the mindset, just like I did here, and say, this is a thing. That's something that we have, that's something that we're seeing, like a change in a pupil or changing on an eye, or like a foot twitch that's associated with something else. That's what we want our people to see. So I think within reason, with the proper mentoring, somebody can go to being from zero to proficient at this with 2 years. 2 years of learning. It takes a year to get through all the material if you're really chugging through it and doing. There's 20 modules, so you can get through the 20 modules in about a year if you do 2 a month. Each module is about 15 hours. And then the training, the in-office hours, if you've got somebody local, which I think the best one local to you is Dan Lane, if you can get into that office and just shadow, like just be a fly on the wall and watch, that's the first step to being good at this stuff. Our residency program right now, we offer, it's 2 days a week, paid per diem, and they can do whatever they want the rest of the week to make ends meet. We pay for their CARIC modules, so we pay for their 300 hours to have enough hours to sit for the board exam, and we also pay for their board exam. And it's a 2-year program to get them up and ready, trained, and pass the board exam. It's guaranteed. What are we paying? We're paying guaranteed 2 days a week, $300 a day to start. And then once they get to a point where we know that they can get a patient better and we know that they can see what we're seeing, then we expand those days once they have patients to fill them. So the goal is to get people to a 5-day-a-week thing. At some point, it's just going to be a straight up residency that we're going to be offering through our business. And we're hoping to have take on a new resident every year for each clinic that we have. And we're up to 7 clinics now. But right now, we're just starting with 1.
Okay, great. No hands, no nothing in the chat here.
I think some people have it on play and they'll come back in an hour to interact. No worries. Yeah, so that's it. If you have any questions or you want more of this style, we can do that. If you guys want me to come back for a fourth year next year, I'm more than happy to do it, and we can use this. We can use a more teaching style. We can use more of an interactive style, like we did here. Whatever you guys need, whatever you guys want, whatever you feel like is going to be helpful for you and your patient base, I'm happy to do it.
Well, I certainly appreciate you doing this, and I'm sure the others do as well. Unless anybody wants to speak up, I don't know what else you'd like to accomplish here.
Whatever you need, I'm happy to answer questions. I don't know if people are. I think we're all set.
All right. Well, thank you. I guess we'll wrap this up, and this recording will be available for those that weren't here, and we'll be in touch with you regarding other things. So once again, thank you, and probably see you again.
Yeah, hope to see you all soon. Have a good one.
Thank you, Doc.
Bye.